All right, we're getting there. We are live. Okay. All right, so we are live, Dr. Julie.
Yes.
All right, give me 1 second. I'm just gonna set this up really quickly right here. Hi, guys. We are live with Dr. Julie DeJoya tonight, and we are going to be talking about breast cancer awareness. We're really excited about it, so just give us a second. We're getting tuned in right now. Okay. Wonderful, wonderful, wonderful. All right, Dr. Julie, how are you today?
Feeling great. So nice to be here. Thank you, Leslie.
Yeah, absolutely, absolutely. Give me 1 second here. Okay. So I'm just going to wait a minute. I'm going to let some people tune in. We will be talking about breast cancer awareness today. We are sitting down with Dr. Julie DeJoya. We're going to discuss breast cancer symptoms. We're going to talk about self-check and frequently asked questions. I do want to take this opportunity to let you know that you can leave comments in the comment box down below. And if we have time at the end of the live stream, we will absolutely try and get those live questions that you are asking and have Dr. Julie answer those. Earlier in the week, we did post on our Instagram and our Facebook asking if anyone had questions for Dr. Julie. And we received quite a few. So we've selected a bunch of those questions to address tonight while we have her here. All right, so just want to give another minute to let some people tune in and give it 1 second. I'm also going to share this because I know I have a lot of girlfriends that should be watching here today.
And I will too.
Yeah, absolutely. Go ahead and do that. Let's see here. I want to make sure that my girlfriend can tune in here too. Wonderful.
Great. We're sharing is caring.
Yeah, absolutely. So let me see here. All right. So guys, today we're going to be talking about detection and self-examination and different ways to educate yourself on breast cancer. It is Breast Cancer Awareness Month. It's really important for us to know these things as women and even as men sometimes also, as Dr. Julie and I discussed earlier today. So let's just take a look right here. So guys, I just want to also say that the best way for us to get our message across is for you to share this live stream. So if you do see us live on Facebook right now, it would be fantastic if you would push the share button down at the bottom so that this message can be shared. This is life-saving information that so many women need to know. And we just want to impart and share this knowledge all across Jersey City and beyond. Without any further ado, I'd really love to introduce my guest today, Dr. Julie DeJoya. So Dr. Julie DeJoya, she is a breast surgeon at Jersey City Medical Center, Inglewood Hospital, and Overlook Hospital. You are a diplomat of the American Board of Surgery. She is also the chief of breast surgical services at the new breast center that's being built over in Journal Square by Englewood Hospital. And you also are a breast cancer survivor. So Dr. Julie, thank you so much for being with us today.
Well, thank you for inviting me, Leslie. It's so important we get the word out. October is the month to think about breast cancer and all of those women who have been saved and who have endured this disease, and we want to save many, many more and prevent it someday. So Thank you for having me.
Yeah, absolutely. So I also do want to mention that you were born, raised, and are practicing in Jersey City. So you are Jersey City through and through.
Absolutely.
And I think it's really fantastic that you and your husband are kind of a team, because he's actually the chief of plastic surgery at Jersey City Medical Center. So you guys are living together, working together, playing together, everything.
We are very blessed. We're very happy to share this life and this adventure together. I can't be more grateful.
So fantastic. So let's get into it, shall we?
Yes.
Okay, great. So some questions came in throughout the week from different people throughout Jersey City, and these are the questions that they submitted. And so we've kind of condensed them down into the, I guess, most commonly asked questions that came into us. So starting right off the bat, what is a mammogram?
Excellent question. A lot of people are confused and frightened by the idea of it. It is simply a very low dose X-ray. And what it's able to do is to show the architecture of the breast, and it can truly detect breast cancer at its most microscopic size. So it's an extraordinarily helpful way to find breast cancer early. And for that reason has been the mainstay of breast cancer detection today, and it still remains so. So it's a low dose X-ray.
Can you tell us how the mammogram is done?
Sure. It is a specialized machine, and these again are very low dose radiation because we want to limit radiation exposure, especially in our young patients, but in all patients. And it involves positioning plates that are not tightly, but snugly applied to the breast so that the x-rays can give an excellent image of the inside of the gland. And in a screening mammogram, there's usually 4 pictures that are taken, 2 of each breast. If something is being looked at more carefully, there may be additional views, but it is a very quick procedure. It should not be painful. And again, it's a life-saving means of keeping your precious life safe. So I do encourage women to not be afraid. I know there's a lot of mythology and urban myth, but it is not painful, and it is so vital to keep you safe. So it's done in breast centers. I do encourage women to go to designated breast centers because they have trained breast radiologists that are especially attuned to analyzing breast tissue. And for that reason, it is important that you have a high quality exam and that you have an excellent interpretation. The radiology techs are very highly trained, and the radiologist is right there to evaluate the images at the time they're performed.
Absolutely. So another question that came in a lot was, when should one get a mammogram?
The American College of Radiology suggests that every woman should have a baseline mammogram at the age of 40 and every year thereafter, for as many years as they're able to understand why they're getting the mammogram and the benefits of screening. So in certain individual families and women, they may start earlier if there's an earlier history of breast cancer in the family. And we individualize mammograms in that population in a special way. But for the general population, the first mammogram should be at the age of 40. That's in the absence of family history and the absence of symptoms or clinical concerns.
So if there is a family history of breast cancer, when should someone go? If your mom had it, when should you go?
Well, the high-risk surveillance studies have shown that we like to screen families with a history of breast cancer in young women 10 years earlier than the mother's diagnosis. So if the mom was diagnosed at 45, we probably want to start screening at 35. But remember, we also have additional technologies that are not radiation involved that can help do a very sensitive analysis of even younger women in their 20s. But women should not think a mammogram is a magic thing. It is an important screening tool, and it should be used appropriately. We are very careful to limit mammograms to women that truly need to know what that shows.
Right. The other question that came in a lot, and I know you and I talked about this a lot in the past 2 weeks, is self-examination.
Yeah.
We know we've seen the advertisements where you're in the shower, check yourself while you're in the shower. So can you tell us more about self-examination?
Yes, there's been a kind of a change in the teaching of women about breast cancer detection, whereas in the past it was almost like a structured exam. I think sometimes that can lead to a lot of concern or even denial among patients if they think of it as a test. So I think the emphasis should be now, especially in our young patients under the age of 40 when they are not being screened, is that they should be breast aware, meaning they should understand what the normal breast exam is. Every woman is so uniquely different, so it's very difficult to have a template, but each woman should be aware of her breast. And the best time to really check it is not every day or every night or every Friday. It's really right after the period is finished, because that's when the breast is least tender, least lumpy, and least frightening. If you examine your breast before your period, you may be alarmed by thickening or tenderness. And for that reason, we discourage random breast checks and ask women to train themselves really to do this right after their period ends, which is when they are they're most able to understand the normal anatomy. For women who are not menstruating or postmenopausal, we say pick one day, the first day of the month, the 15th day of
Right.
the month. Just make it a routine. And again, if you miss the 15th day, the 16th day is fine. Don't skip
Yeah.
an entire 2 months, but just be aware of what your breast should feel like so that if there is a change, you'll be able to be aware of it sooner than if you're ignoring the whole subject.
Right. So basically, you are your best advocate and you
Yes,
know what your normal is. So if you're
absolutely.
checking yourself after your period every single month, you know what your breast feels like, what's normal to you. And if something occurs and you're used to one thing and you feel something different, you have just self-detected for yourself an abnormality that you might need
Right.
to go to the doctor and check out. And that I think is great and very important information,
It
which
is.
leads me to the next question that came in, which is how do you do a self-examination and what exactly are you feeling for during that?
Well, the most important thing about breast self-exam, it shouldn't be an hour. It should be about 6 or 7 minutes, perhaps. It shouldn't just be a couple of squeezes and that's it. Women need to know that the breast gland goes up to the collarbone, it goes down to the rib, it goes over to the armpit area, and right into the middle of the chest where the sternal bone is. So that all of that tissue needs to be assessed during an examination. It used to be that we taught women to do the exam in circles and like concentric circles from the nipple outward. Now we like to go up and down. We think it's less cheating and we cover more territory more quickly. And you use two fingers. The right hand would examine the left breast, the left hand, the right breast, and we use two fingers to feel through the skin down to the chest wall. And this should be done not in a panicked way, carefully and thoughtfully. And in the shower, it's easier because with the soapy skin, it's a smoother gland to appreciate. And then when you dry off, you can also look in the mirror with your hands on your hips to see if there's any dimpling in the skin, any redness, or any other thing that seems different. But it should be remind my girls and my ladies that the breasts are dynamic glands. They change dramatically throughout your menstrual cycle, through pregnancies and through menopause and perimenopause. So the fact that you're feeling things, please remember that the vast majority of things that patients become aware of are normal. But the reason why breast self-awareness is so important is because you can bring things to the doctor's attention that perhaps they wouldn't be aware of if you didn't know about it. I also think, Leslie, we talked about the fact that in your exam with your GYN or your primary care, have the doctor show you a good breast exam. Because sometimes many doctors are rushed or they're looking at different problems, and you need to be able to take control of your own exam when you can't, perhaps get the time in front of the doctor that you really deserve. We're all rushed these days. So take your time to ask the question and know how to do it right. You won't be more afraid. I think you'll be more confident.
Again, yeah, you are your best advocate. Ask
Yes,
your doctor to teach you how to examine yourself.
right.
100%. Yep.
Mhm.
So another question, which was very common, was what are the different stages of cancer? I think we hear a lot of different names thrown around when we hear the word cancer, things like triple negative. So we want to know, I guess, what are the different, sorry, that was, I was talking the different stages of cancer and the different types of cancer. So we can break
Right.
that into 2 questions
Yeah,
actually for you.
it's
Those
good.
are big.
They are big questions. And staging is basically trying to determine how long the disease or the tumor has been present and how far has it progressed. So the earliest stage that we can detect breast cancer is through mammography, because mammography can show microcalcifications, which really look like salt on a tablecloth. They're like tiny little grains of sand.
Mm,
And these are not able to be felt by an exam, either self-exam or doctor exam. They're exquisitely sensitive on mammography. So this is the beauty of mammography, is it can find these microcalcifications, which can represent, although not always, but they can represent stage 0 cancer, which is really the pre-cancer that gives us the best opportunity to intervene before the disease becomes invasive. Once we start talking about invasive cancers, there's stage 1, 2, 3, and 4. Stage 1 is when the disease is small, under 2 centimeters. It's confined to the breast and there's no evidence of lymph node spread. Stage 2 would be a larger tumor, bigger than 2 centimeters, or a positive lymph node, usually under the arm. Stage 3 would be a much larger tumor with more aggressive local invasion. And stage 4 would be distant disease in other organs, such as bone or lung or liver. So
right.
stage 4, and there's a lot of commercials on TV now because there's so many new drugs, and it can be confusing to people. And there's a lot of excitement and there's a lot of hope now, even in stage 4 patients who can have a wonderful quality of life. And remember that every stage of breast cancer is treatable. So we need to not be despairing if the disease is found at any stage, because there's so much that we can do to keep you safe and to keep your quality of life precious and whole. So the stages are important in terms of the doctors in planning treatment, and often, it's very important to stage the disease clinically, meaning what we see and feel, and pathologically what we find in surgery. In terms of the types of breast cancer, we used to believe that breast cancer was one disease, it was one diagnosis, and everybody had mastectomies, and that was basically it. We have learned an awful lot in the past 30 years regarding breast cancer and its biology and its behavior, and it's the individual personal diagnosis of breast cancer in each patient. So that the types of breast cancer, there are kind of 2 main types. The most common being invasive ductal, which is in the milk ducts. And that's why those little calcium deposits on mammogram can often be seen along a duct in a line. So this is where many breast cancers begin. The other type of breast cancer is called lobular, which is more glandular, which is the gland itself. And these tumors can be harder to find. They're not as common as the ductal, but they can often present sort of like a lacy pattern in the gland. So they may be difficult to see on mammogram, especially in young patients, but often they're felt. And this is why the breast exam and the mammogram are not separate. They really have to be combined, because you may see something on a mammogram and not feel it. You may feel something on a breast exam and not see it. Either way, we need to find out what's going on. So invasive ductal and invasive lobular are the 2 most common types. There are subtypes, of course, among these, and that's far beyond today's discussion, but they're important nonetheless. The other issue is the biology of the tumor. And this is where the triple negative description comes in, the hormone positive tumors. And these findings are very important because it can guide our oncologists on how to treat it where it is, and perhaps send it completely into remission before surgery, and certainly keep it from coming back later on in life, which is, of course, a tremendous goal that we have for every patient. So triple negative tumors are unique in that they are more fast growing. They're frequently in young patients. Again, why I stress the breast awareness, very critical in our young population, because these women are not screened, because they're not supposed to be getting, x-rays at age 30, but they need to be breast aware, because these tumors, when found, tend to be found by the patient. And for that reason, we all have to be alert. It's also more common in our African American patients, although it's common in every race and ethnicity. but we are aware of a higher incidence in our African-American patients. And for that reason, we have to go into all our communities and remind them to be conscious and to be aware. The good news about triple negative cancer is that they're highly responsive to chemotherapy, and they can be sent into remission even before surgery. So we often partner with our medical oncologists in terms of developing a plan for each patient as to whether they get surgery first or chemo first. Radiation is also a part of this puzzle. And for this reason, our new cancer center, of course, will embrace this. We need a multidisciplinary team approach for each patient to individualize the proper care.
Absolutely. So it's a team. It's
a
really
team.
a team. It's a team effort. When someone gets a breast cancer diagnosis, it's a team effort between you and the oncologist and all the different people who are going to come together.
The plastic surgeon, of course, and the radiation oncologist. The pathologist is a critical piece. The radiologists help us with different workups once we make the diagnosis. We all are very, very close. We work very closely together because each of us, gives a perspective and a value to where this patient should be in terms of treatment. I think we spoke before that my support group has 40 different women, different ages, different decades, and many of them had completely different treatments. And it can be confusing because one patient had certain treatment, this one had a different treatment. And why is one different from the other? Because each one should fit the patient and the type of breast cancer that they have. So it can be confusing.
Absolutely. And like you said, over the course of the last 30 years, there have been so many medical innovations and new discoveries about breast cancer. Over 30 years ago, breast cancer was kind of a singular thing. Oh, you have breast cancer. It's one thing.
Right.
But now it's a million different things, right? There are so many different variations and so many different treatments, which is absolutely fantastic. And we were so grateful for that.
Yes. Yes, and it's true. And I think it's important that the patient understand that many of the decisions that are made have to be understood by the patient. And that can be kind of, very unsettling at a difficult time when you're dealing with the diagnosis, overwhelming, which is why it is very important that the patient feel confidence in their team and be prepared to get second opinions. And we welcome that, the discussion and the family consultations, very critical. We also, depending upon the patient, we have fertility consultations, we have mental health awareness and anxiety and depression consultations, physical therapy. We try to get people ready for the surgery, and we certainly want to cherish them during and after the surgery as well. But it is such an important task because it is the most common cancer in women. We know that lung cancer kills more women still, unfortunately, but the breast cancer is so ubiquitously present that no one can afford not to be aware of it and not to be aware of the help that's available, because the isolation that comes with finding that lump can be devastating, and it can cost precious months in terms of delaying treatment. I think we talked a little bit about this year more than ever. We have to encourage women, if you have something that needs to be addressed, please safely and socially and consciously with masks, seek help. Do not hide. Do not wait, because there's a lot we can do.
A lot of people right now are conflicted on whether they should be going to the doctor,
right? Whether they should get a mammogram.
Risk of exposing themselves is worth it. But we're here to say that it is worth it. You need to go get yourself checked by the doctor.
And I think one thing that the pandemic has done is stepped up all of our games in terms of cleanliness and patient protection, and making sure that everything is approachable and clean and balanced, so that it's not a mob scene or a frightening type of an environment. But please remember, it's so important not to wait. We're here for you.
Time is of the essence, for sure. Like you said, cancer is treatable at any stage, but it's much easier to treat when early detection.
Yes, absolutely. And the choices are more acceptable to patients too. The choices are, I won't say easy, it's never easy, but they're easier to digest perhaps. than when we don't have choices.
So guys, I just want to take this time really quickly to remind you that this is really life-saving information that Dr. Julie is giving out. And so if you think that you have some women in your life that need to hear this, you can feel free to come back and replay this for them. But if you see the share button down below, please share it. We do want to get this information into as many ears as possible. So I'm going to move on to the next question that we received this week. Are the suggestions for detecting breast cancer different if you have breast implants?
Okay, breast implants do not interfere with the screening and detection of breast cancer. Thankfully, you should always tell the mammogram technologist that you have implants, fill out the questionnaire, appropriately. But the mammogram is so sensitive at picking up microcalcifications, it can do that easily in patients with breast implants. And for that reason, it should not cause unnecessary alarm or concern that it would delay diagnosis. The implants are generally behind the muscle, meaning the muscle on the breast itself is right up under the skin where it's supposed to be. So when you do a breast exam, you can still feel the tissues. Ironically, it is women with breast augmentations usually have very dense, tight breasts to start with, which is why they sought out the augmentation. And for that reason, it is important that these women frequently get ultrasounds in combination with mammograms, just as surveillance, because the breast, even without an implant, would be dense on a mammogram. So it's important to remember that breast density, whether you have an augmentation or not, should require an ultrasound as well. And insurance companies must pay for this as part of surveillance. So no, it should not interfere with the breast exam, the examination of the armpit, the skin. The radiologists have special views. You may get more than 2 views on a screen, but they can push the implant aside to get better views of the angles. So it is safe and important that women with implants be screened. It will not rupture the implants, I promise. It won't cause any danger to the augmentation. And it is critical that you be screened just like everybody else. And don't be afraid.
Absolutely. And one of the things while I was doing my research this week, typing in some commonly asked questions through the internet, I did see that asking if getting breast implants would increase my chances of getting breast cancer. That was a question. So I figure if we're on the topic, you can address that as well.
Sure. We do not have any data that would suggest that breast implants are related to causing breast cancer. However, there has been research, because so many millions of augmentations and breast reconstructions for cancer have been done worldwide, that we're careful to study our patients. And in the past year, there was a lot of stuff in the press, and we could go on and on about this too, about a implant related lymphoma. Now, that is not a breast cancer, but in certain types of implants that had been used in the past, they saw a small percentage, but women need to be aware. When you make a decision, you have to be informed. And that means not hiding truth. You must always be truthful, so that women who have had implants may have read about or been notified about this specific type of anaplastic lymphoma that has been associated with implants, both for augments and for breast reconstruction, that were connected to a particular type of textured implant. That implant is no longer used, and it was not widely used. And it was used, believe it or not, thankfully, in a group of women that were studied very carefully. But you need to be aware of that. That disease itself is not a breast cancer, but as in any enterprise that requires thought and understanding, women need to know if they have a sudden swelling on one of the reconstructed or augmented side. Sometimes people lose track with their plastic surgeon and they don't really know what to do. Please contact the plastic surgeon or go to your own doctor and be referred to a breast surgeon, because sudden swelling is an important sign of this lymphoma. It's very rare, and I don't want to cause alarm in the population. My job is to inform and to let people know that this also is treatable. And for that reason, if there is swelling, usually on one side, in a patient who's had an implant even years ago, please come out and be checked, because it's important that we keep you safe. But by and large,
it's not worth it not to say anything.
yes, you have to be able to step out and step up.
Absolutely.
Yes.
Also, guys, if you have any questions at all, please pop them into the comment box below, because we'll address some of those live questions coming in at the end of the live stream in a few minutes. So another question is about, and we did get a couple of these, about male breast cancer. How common is it? How do they detect it? Is it the same as for women? And what is their treatment if it is different than the treatment that you would give a woman?
Yeah, it's important because we have to talk to our men. It is, of course, a very unusual diagnosis in males. It's 1% of all breast cancers are found in males. But remember, there's 250,000 women with breast cancer every year. So that's going to be 2,500 men. There used to be an idea that this was, again, a disease of older men with hormone imbalances or treated with estrogens for cancers, et cetera. We know now that that's not necessarily true. Male breast cancer can be a sign of a genetic mutation in a family. It's that rare, so that males who are diagnosed with breast cancer are always tested for a genetic mutation. But it should be said that the vast majority of lumps that women find or that doctors find in women, or even things we find on mammograms, are benign, which is why we're always criticized for doing too many benign biopsies. I like to be criticized for that. I just don't want to miss any cancers. However, for a male with a breast mass, 50% of them are cancers. So if a male has a breast mass, it's very important that they step up and get it checked. Because again, the incidence of breast masses in males is not that high, but the incidence of cancers in those lumps is very high. And my youngest patient was 28. He's still alive, God bless him, 25 years later, and he's doing fine. And we've had personal trainers who've had them, young men, police officers, just normal people, just like breast cancer. It's a disease of normal people. And for that reason, men need to be aware that if they have discharge from the breast, or they have a swelling or a lump or significant chronic pain, they need to step up. And again, it's treatable. And it's so important that they understand it's not a girl disease, it's a cancer. And it has nothing to do with anything other than get those lumps biopsied. The other thing we talked about a little bit is that males get breast pain. And sometimes they're very frightened by that. And again, think it's a girl thing and whatever. It's not a girl thing, it's a hormone thing. But males, I hate to be specific or controversial, but smoking weed can cause hyperdevelopment of breasts in males. It's a known factor. So can alcoholism or alcohol binging can cause significant breast pain. We don't believe they cause breast cancer, but they cause breast pain, which causes anxiety and leads to mammography and serious conversations about lifestyle. But men who take steroids for bodybuilding frequently have hyperdeveloped breasts and testicular atrophy. People sometimes are heedless about what they're doing with their bodies in the name of physical fitness. They may be doing themselves some serious damage. So it is important that breast pain be addressed respectfully and not minimized and understood. Because breast pain in women or men, it scares the patient. I think the most common reason I see patients is breast pain, and they need to be reassured completely that there is no cancer. Although ironically, breast cancers rarely present with pain. I don't say never, but very rarely, which makes them so treacherous. So,
absolutely. And I think there's kind of like this masculinity thing where men
yes,
don't like to admit when they're in pain too.
right.
So it's like a double factor that, oh, this is a woman's disease. And then on top of
Yes.
it, I don't want to make myself vulnerable and admit to being in pain or
have a mammogram. But
or have a mammogram.
My men cancer patients are so eager to go out and tell their pals and their buddies, please check it out. And again, one of the big problems with male breast cancer, for years, we didn't find it till it was already in the bones, because the men didn't want to come out and talk about it.
It's
so
terrible.
we have to get away from that. Yeah, it's tragic, because the prognosis for breast cancer in males is actually the same as females based on stage. So early diagnosis in a male, we can go for the cure just as we can for females. So they shouldn't be afraid or embarrassed But men are much more shy than women. Have you ever noticed that? They really are. Women are kind of out there. I guess it's because
Well,
we do so much out
we've
there.
been taught to advocate for ourselves, thanks to you, Dr. Julie.
I know. I know.
Okay, so next we want to talk about you actually mentioned this a little bit earlier. What are the treatment options for breast cancer, such as chemo, radiation, surgery? We did talk a little bit about this, but if you could just really quickly, again, for anyone just tuning in.
Sure. And again, because things have changed so much, our understanding of the biology of these tumors has changed so radically in the past, really 5 years, that many tumors that have a specific type of a biology, like the triple negatives or what we call HER2 positive, this is another marker that we look at on the tumor biopsy itself, that these types of tumors can be driven into remission and downstage, meaning a large tumor can disappear or go to a very small stage that can allow us to do, let's say, breast conservation rather than a mastectomy. So many of these tumors respond very quickly and very beautifully to see them dissolve with these chemotherapies. So we can, in conjunction with our medical oncologists and our radiologists, where we stage everything and then we decide which one needs to be treated which way. Neoadjuvant, which is before surgery, chemotherapy is frequently given for these high-grade tumors. And certainly larger tumors or node-positive tumors are frequently treated with chemotherapy up front. The surgery then becomes really limited by the extent of the disease, number one, and the size of the breast. So, if you can have a large tumor and a very large breast and be able to do breast conservation, you can have a not that big tumor in a tiny breast, and you really can't do a breast conservation safely. It should be said, however, that plastic surgery has evolved dramatically in terms of what we call oncoplastic surgery. So we're doing types of reconstruction even for lumpectomy patients so that we can maintain the shape and flow of the breast in conjunction with radiation therapy postoperatively. So what we try to do is work with the plastic surgeon, planning the incisions, planning the extent of tumor resection, giving us free margin, and then the plastic surgeon, with their magical skills, can put the breast back together again and have a beautifully symmetric result. We're also doing breast reductions for breast cancer. Again, breast reductions are not cosmetic surgeries, they're quality of life surgeries. But in terms of cancer treatment, they can rejuvenate a patient who may have been thinking about reduction and now they have a tumor. And guess what? It's a great choice and it's a safe choice. So we have lots of variables that we can do. And in terms of mastectomies, there's all kinds of reconstructions that are available now, using the patient's own tissues, using expanders, using different ways to place the implants. So that is why the plastic surgeon is a critical part of the discussion, because that discussion should be preoperative, not post, oh my God, what have I had done? It should be before you go to surgery, not when you're like, why did I do this? And you don't want to have a patient survive for 50 years and cry every day. You want them to be happy and whole and fulfilled. So it is important. And the state of New Jersey has mandated that every patient with breast cancer deserves reconstruction. So you can fight for that. The insurance companies cannot deny it. It is not cosmetic. And that includes the other side.
New Jersey.
Yeah, the other side has to be symmetric. The goal of reconstruction is symmetry. So again, there's exciting things and valuable things that patients, when they're going through such stress, need to understand. There's a lot of people standing there to help and ready to help.
Thank you. So this is something that came in a lot, actually, because people were asking about genetic testing. Should they get genetic testing? Who should get the genetic testing, and where the advancements that have been happening over the past couple of years? Can you talk a little bit about where we're at and when that should be utilized?
So we are right on the cusp of giant findings in terms of genetic testing. The first people that identified the genes were out in Utah, and they found the BRCA1 and 2 genes, which, as we all know, Angelina Jolie, God bless her for sharing that. She did a lot of good by just saying the word that Angelina Jolie, that beautiful girl, had all this preventive surgery because she lost her precious mother who had the gene as well. So she's done a lot of good. And everyone who's listening today, can do just as much good by telling your friends and telling your family what we're talking about today, because you really do make a difference to spread this word. But genetic testing now is mandatory in any new breast cancer in a patient who is premenopausal. We do this automatically now because it is important that young breast cancers be evaluated, because if they do have the gene, and only about 10% of them will have the gene, at least the genes that we can identify, those women are treated differently surgically because they have a higher recurrence rate with lumpectomies. But what I keep stressing is that genetic testing should be done in any family where there's been a patient or a mom with premenopausal breast cancer, even if it was many years ago and they didn't have genetic testing. If your mama died of breast cancer or had breast cancer in her 30s or early 40s, you do qualify for genetic testing. And the beauty of genetic testing is to try to find the gene before the cancer finds the patient.
Mhm.
And it seems so hypocritical that you have to wait to get breast cancer to get tested for the gene, when people should be tested before they have the cancer, because that gives them an opportunity to intervene and to literally, prevent the disease, which is everybody's goal. Now, obviously, there's a lot of controversy about patients afraid to be tested. The tragedy is so many patients who come to me with breast cancer, their first question is, am I going to give it to my grandchildren? Because they always think of the grandchildren. I don't know what happens to the daughters, but the grandchildren are so always more precious. I don't get that. But anyway, that's because I don't have grandchildren yet. But
Yeah.
the point is, they're so tortured by, did I do this to my family? And this is not about guilt. This is not about, liability. This is about defining risk and making intelligent decisions to keep your family safe. I should also remind our patients and people watching that males can inherit the gene as well. So male breast cancers always tested for the gene. Very few of them have it, less than 5%. And even though it's a small number of males with breast cancer, an even smaller number has the gene, but some of them do. And that can save the lives of the women in that family. So genetic testing, young women with breast cancer, mandatory. Males with breast cancer, mandatory. It used to be that Ashkenazi or Eastern European Jewish families, and this population literally saved thousands of lives because the gene was found in this population. And for that reason, we're eternally grateful. But they have, whereas the incidence in the general population is about 1 in 200, in the Ashkenazi Jewish population, it's about 1 in 40. So that's significantly higher. Now, it used to be that insurance companies would pay for genetic testing for this population. However, now they're starting to say they only pay for it if you have cancer, which is insane because you're trying to prevent the cancer. So we have to do more in terms of speaking out about reality and common sense and insurance, coverage. Gratefully, there are ways, however, for even people who don't have insurance to be tested for the gene. And I don't want to be doing a commercial for anything, but the point is, it is available at a relatively low cost, even without an insurance, coverage. But the insurance people should cover it. I mean, let's face it. So
Mhm.
not, the woman that discovered the gene, Dr. Mary Claire King, she believes that everybody should be tested for the gene, like we test the babies for HIV and for other things, because if you can find the disease or, find out who's at risk, you can put them in high risk surveillance programs from the get go. So there's a lot of controversy, but certainly young women absolutely have to be tested, and males and females can inherit the gene. Each child has a 50% chance of getting the gene. And it's
Mm.
scary. I get that. But guess what? So's cancer out of the blue. So we have to take advantage of the knowledge that is available, as perhaps weak as it can be and as confusing. It's what we have, we can really use to change the course of lives for the good.
Absolutely. Absolutely. Um, so another question that came in is there a diet I can follow that will lower my risk of breast cancer? And I think answering this question and also kind of circling in any kind of like lifestyle things, are there any things that we can eat, supplements we could take, activities we could do that would lower our chances of getting breast cancer? I think is what they're kind of asking.
Well, I think true. And the millennial population that we're seeing now, and God bless you all that are really causing a renaissance in Jersey City. I love each and every one of you for helping us be more healthful and more conscious socially and every other way. But yes, I can understand why people want to know what they can do to stay healthy. Obviously, we know there is data on exercise and on wellness. Unfortunately, they've tried low fat diets and no keto diets and low carb diets. And unfortunately, breast cancer is completely democratic in terms of it affects every population. The young patients with breast cancer tend to be slim, active, healthy people who don't smoke. They eat broccoli, they shop at Whole Foods, they prepare everything. I mean, they bike and they hike, and these are the healthiest people in the world, which is why when they're diagnosed with breast cancer, they're devastated because it doesn't make any sense. But breast cancer is not by definition a lifestyle disease. We do know that being overweight as a young woman can be protective against breast cancer, and being overweight as an old woman can be protective. It can be a risk factor for breast cancer. So yes, weight control is important, but you can be 98 pounds soaking wet and find that lump. So don't think it's a safety net. Similarly, for other things, having 12 children before you're 30, we know that there are some things that seem to have a protective effect, but truthfully, I've had mothers of 12 children with breast cancer. So it's not that alone that can keep you safe. They did a study on early pregnancy and protection against breast cancer. It was pretty big study. And they estimated that if they could induce a pharmacologic pregnancy in 15-year-olds. Of course, you don't want your 15-year-old to get pregnant, but the point is that might be a reduction in breast cancer. But these are big unknowns. I mean, exercise absolutely is good for you, but it's not enough. Maintaining a normal weight is great for you, and I encourage it. And especially with exercise, stay active, keep moving. But again, it's not enough. It's not enough for you to get out of getting a mammogram, to get out of checking your breasts, and get out of understanding that there's no magical formula. The thing about breast cancer and any kind of supplements is that we know that hormones after the age of 45 are not good. That's why we don't do hormone replacement anymore, because it does cause breast cancers. We know that. But other than that, I don't want to make people think if they don't never have butter again, they'll be safe. Live healthfully, eat real
Eat the
food.
butter. Eat the
Yeah,
butter.
eat the whole butter, no margarine, eat the fresh vegetables. You know what to do. You're probably the most health
Have
conscious
a healthy
generation.
balance across your life.
Yes, balance. And of course, smoking is a factor. Smoking causes breast cancer. We know that. We used to think it only caused lung cancer, which is the number one killer of women. But the point is, it does cause breast cancer. It causes every other head and neck cancer as well. So we could really decrease the rate of all cancers if we could get the entire population to stop smoking. And yes, I also mean weed.
Absolutely. So we had a live question come in, so I'll just ask you. It says, are there any programs as an alternative to insurance for genetic testing?
There are commercial insurance companies that will do genetic testing for a fee. I think the one I'm aware of is about $200. I know there are other kits that they advertise online, and I can't vouch for them, but they can detect not all the genes that we're talking about. There are about 15 recognized cancer genes, and then the big two, of course, are the BRCA1 and 2s. But there are commercially available kits that you can send away for. They'll send you a saliva specimen little cup, and you fill out the papers and send in your check, and they will give you the result. So you do have access to genetic testing. Now, what you do with that information, though, darlings, is that you need to talk about it with a doctor, because again, the fact that you don't have a gene is no protection about not getting cancer. So it's good to know you don't have it, and that's a wonderful thing, but it doesn't give you any added protection. And if you do have the gene, you have to understand what it means. And that should always be done in a comforting, intelligently conversant, non-hysterical way, so that you can determine exactly what that means. Because we don't want people learning this information in isolation and again, denying themselves treatment out of fear. But again, the insurance companies, if you have the history in the family to justify it must pay for it. And if they don't, you got to raise holy hell. I hate to use that term, but you got to speak out. You got to speak out.
You heard it from Dr. Julie right
That's
here.
right. You heard it from me. I believe it too.
Absolutely.
Usually if you yell and scream, they'll fold. You know that.
Yeah.
It just takes a little yelling and screaming.
Is that the Jersey City in you?
It is the Jersey City. It is, God bless Jersey City, and all of you transplants, you're going to talk just like me in about 10 years.
Yeah.
So watch out for that.
So another thing, a question that came in that we can address, I know we're getting towards the end here, but does breastfeeding lower my chances of getting breast cancer?
Well, we always believe that it's a very beautiful and natural thing to do, and it's very good for the baby and the mama. And you'll never hear me talk down breastfeeding. Does it prevent breast cancer? Nobody knows. As I said, most of my patients have breastfed their babies. You know, they do what they can. They do what they should. I certainly would never discourage anyone. If it helps the baby, to say, yes, it prevents breast cancer. But I can't lie to you. There's no data that says you must breastfeed that baby or else you're going to get breast cancer. But the truth of the matter is there isn't a lot of data, especially in young patients. We have a lot of young patients with breast cancer, but we have so many older patients, and we have thousands upon thousands of research articles on older women. And the younger women, we have to really cherish on a case-by-case basis, because we have to look down the long path of their lives and make sure they have important information about fertility preservation and, you know, egg retrieval and embryo savings. I mean, there's a lot of discussions that we have when the diagnosis is made in the young. But again, good people and very intelligent people are there to help every patient make the proper decisions. And it's right in the community. So, you know, we're not far. It's very important, you know.
Yeah. We're right here at the end for us. And it's kind of sad because I feel like you have so much information to give out to everyone. So I hope we were able to ask these questions. I hope our viewers were able to absorb what you were saying. Thankfully, this will be available on our YouTube channel and on Everything Jersey City's Facebook page forever. So we can always advise people to come back and watch this live stream. But I think to close out, we should just address what we talked about earlier for anyone just tuning in about the importance of the fact that I know we are in the middle of a pandemic and COVID is very real and we need to be careful. But still we need to go to the doctor, and I'll let you take that from there to close this out.
And I realize that there's been such a lack of, again, educational opportunities in the community. We're very much looking forward to doing our seminars again in the churches and the communities. But if it comes to a point where, Leslie, you get a bunch of questions and you want to do this once a month or every couple of months, we'll do a little question answer, because people need answers, and I'd be happy to help in any way that I can. But please come out. Don't be afraid. The really fear is much worse than cancer. Cancer we can treat and we can get you through it. But fear is just an intangible purgatory. So please be aware it's safe to come out and be careful and just love your families, and remember you have precious lives to stay well and to stay healthy. And if you need me, Leslie will get me back on again and we'll do this all over again.
Yeah, guys,
Thank
if
you
you
so
have
much.
more questions for Dr. Julie, feel free to put them in the comments below. You can also feel free to send us an email and let us know if you have an idea for another live stream that you'd like to see or information that you'd like to have. Dr. Julie, it was such a pleasure to get to know you over the past
Thank you, Leslie,
weeks.
and I greatly appreciate your support of Breast Cancer Awareness Month. God bless you, sweetheart. Thank you. Thanks, everybody.
Bye.
Bye. Bye-bye.